Hi everyone, welcome back. I want to thank you for joining me today, and I also want to thank for those who watched my presentation last time, which was about 3 weeks ago. And let me briefly introduce myself to you again. I'm one of the 5 directors in GAO, and I'm a prosthodontist. And I'll be talking to you mostly about prosthetics. And Global Academy of Osseointegration, which I belong to, has been focusing on educating young dentists domestically and also internationally, and also share our unique concepts and protocols in implant dentistry with the rest of the world for more than 10 years now. Last time, we've talked about the rationale for accelerated loading, whether it's early or immediate, and I mentioned it can be achieved by improving both primary and secondary stability. We could increase secondary stability faster by improving the implant surface, which would induce faster new bone formation. And if we could also delay or maintain the loss of primary stability by improving the design of implant and also our surgical techniques, which eventually reduces or even eliminates the dropping or the danger zone of total stability. This is what we've talked about last time. Today, I'd like to talk to you about objective methods to evaluate implant stability. To assure whether we actually improved implant stability or not, we probably need a way to evaluate implant stability objectively. There are numerous methods out there used by clinicians for this purpose, but no single method has been proved to be the way. There are still doubts and controversies about pretty much every single method. I named my presentation today, The Myth About RFA. That means I'll be talking about the methods to evaluate implant stability, and RFA happens to be one most popular method for that purpose. I will discuss RFA with you too, but it'll be, I think it'll be more like criticizing it a little bit. Okay, can we really evaluate or even quantify implant stability? That's the question I want to ask you from the start. Any instrument for this purpose should satisfy at least 3 requirements, I think. First, the measurement with those instruments should be repeatable. It should not change for the same object in the same condition. And also, the measurement should be specific and sensitive enough to differentiate between objects and conditions. There are numerous methods introduced in literature, and most of these are not objective enough or does not give you the quantified result. This happens to be Dr. Homlei Wang's review article. In this article, percussion or radiographs can be quite subjective, as we all know. And the cutting resistance, insertion torque value in another word, this cannot assess the stability changes after implant placement. This is pretty much a one-time measurement only during implant placement. Well, histologic analysis would probably be the most objective method to evaluate stability, but it is too invasive, isn't it, to be used in clinic, to be used on patients. With reverse torque test, it can cause irreversible deformation in peri-implant bone. So it's more like a pass-fail test. And it cannot quantify the degree of osseointegration. There are two most popular methods in something called vibration analysis. One is perio test, and the other is RFA. For perio test, people have been using perio test to assess the mobility of natural teeth. This is what this instrument is for originally. For example, periodontally compromised teeth. But this instrument was not sensitive enough to evaluate implant mobility, which is much smaller than the ones with natural teeth. RFA, the resonance frequency analysis, basically measures the stiffness of the implant bone junction right here using resonance. And everyone knows Austell Mentor, which is one most selling instrument in terms of measuring implant stability in the world. But let me ask you another question. Can we or should we really trust RFA? Is it really the best we've got? Maybe so, maybe not. Some people believe it's reliable and the most accurate method to evaluate implant stability, but some don't. Interestingly enough, almost always you can find studies that are in favor of certain things and also some studies opposing it at the same time. My personal belief is that RFA is not the best instrument for measuring implant stability because of the following reasons. First, RFA sometimes give you false readings, false measurements. This is the diagram I found on the website of Austell. It gives you very specific guideline in terms of loading. For example, when the ISQ is above 65, you can do early loading, it says, based on this diagram. So with this diagram in mind, let's take a look at a case. Well, thanks to Dr. Park, who allowed me to use this video clip, you would notice something very interesting in a minute. The measurement or the reading is 66. $61 now. $66 again. But then see what happened at the end. The implant was not fixed into the bone at all. So So based on the diagram that I've just showed you, 65 in this particular case meant nothing. It looked fixed into the bone, but it wasn't. Let me show you a case. This patient presented with a maxillary anterior 6-unit bridge with periodontally compromised abutment teeth. Patient did not want any removable prosthesis and did not want to do anything on the lower arch. And this is what patient looked like intraorally. And to make long story short, I ended up placing 7 implants and try to restore with 3 pieces of fixed restorations. 2 3-unit bridge in posterior and 1 6-unit bridge in anterior. And titanium custom abutments seated in the mouth and finished with final porcelain work. Patient liked it, and I did too. But this is the X-ray after about 4 years. You can see some bone loss starting from the crestal area down. So some of you might think, we might have to do some treatments for this implantitis and try to save the fixture. So someone might do some bone graft, and try to preserve the implant as it is. But well, that wasn't my choice of treatment. I planned to take the implant out and try to place another implants right next to it, right there, for the lateral incisor site. And that was my plan. So I placed another implants right there for number 22 site, and this is 13, which had the bone loss around the implant right there. And when I placed implant for number 22, the insertion torque was 40. Let me go back. The insertion torque was 40, and I measured the stability with ISQ. It was 78, which was absolutely high. And after about 4 weeks, I tried to measure the stability of number 23, which was failing at that time. So I connected the magnetic peg and measured it, and it was 60. But then while I was trying to remove the magnetic peg, the implant fixture came out with it. So that, which means the implant was totally failed, and then there was no fixation between bone and the fixture. And luckily enough, number 22 implant showed pretty high ISQ measurement, which was only 4 weeks after the placement. So I ended up start making new prosthesis for this patient. So this is what happened. New implant. This implant is gone, and new prosthesis, 6-unit. Okay. Back to the same diagram. When ISQ is above 70, it says you can do immediate loading for single tooth. Does everyone buy this? No offense, but I don't think I can follow this guideline personally. And at the bottom of this diagram, it also says It's not an official recommendation by Ostel. It's like CYA, cover, you know. And second problem with RFA is there's no correlation between RFA and bone implant contact ratio. We've talked about bone implant contact ratio last time, which I mentioned the most important parameter for loading, especially for accelerated loading. Numerous researchers claim that they failed to find a correlation between RFA and BIC ratio. There's another review article. You notice multiple studies saying there is no correlation between ISQ and BIC ratio. Lastly, the RFA value, the ISQ, does not properly or linearly, to be precise, represent the actual mobility or stability of implants. Some studies looked into the relationship between ISQ and actual micromotion or micromobility of implant, which is called value of actual micromotion. There was a correlation between these two parameters, but the correlation was not quite linear. This curve looks more like exponential curve. It's not a linear curve. And this is clearly stated on the website of Ostel. It says the ISQ scale has a non-linear correlation to the mobility. It means this: between ISQ values 40 and 80, 80 does not mean the implant mobility is half of ISQ 40. You see what I mean? So there is no linear correlation between ISQ values. How come ISQ is not linear then? If it's not linear, what's the purpose of using it? When we say we evaluate implant stability with certain method or instrument, it means this: we are not really measuring the actual displacement or mobility of implant. We are measuring something else to assess the mobility indirectly. We're measuring the surrogate parameters, which is called. All these methods, we're not really measuring the actual mobility. What does that mean when we say we measure resonance frequency? We can think of an implant as a simple oscillator, like tuning fork. A tuning fork gives you sound with a unique pitch by resonance phenomenon. When we hit the tuning fork, it starts vibrating or oscillating with unique frequency. It's called the resonance frequency. And we know the frequency, we can calculate the amplitude or the micromotion, I would say. So when we know the frequency, we can calculate the amplitude or the displacement or the mobility. They are inversely proportional to each other. So when we get certain ISQ value, we know the frequency, and we can calculate how much the object moves. This sounds great up to this point. But the problem is, the resonance frequency does not have much to do with the actual mobility. Because resonance is a very interesting phenomenon for sure, but here's the pitfall that we fall into. Sometimes we can get too fascinated by the phenomenon. I'm sure many of you have done this. When you keep rubbing around the rim of a wine glass with a wet finger, the wine glass starts making a sound. And because the glass resonates and it gives you a sound with certain pitch or frequency. As you can see in this video clip, you probably not have any sound, but this is a resonance frequency of the wine glass. But if you produce a sound with the same frequency that the glass resonates at near the glass, see what happens. It breaks. This is quite interesting, isn't it? So what actually is the resonance or resonance frequency? We don't want to be fooled by that. Resonance is nothing but the phenomenon of amplification, which occurs when the frequency of a periodically applied force is in harmonic proportion to a natural frequency of the system on which it acts. It's hard to understand. It's complicated, isn't it? So let me explain it in plain English. It's like how a swing works. Standing behind your child, each time the swing comes back to you, so you have to give it a very perfectly timed push. Otherwise, the swing never goes higher. Let's take a look at this suspension bridge in Tacoma, Washington. It literally dances by the wind. But the wind really is that strong? I don't think so. And this is the fate of the bridge at the end. It collapsed. Amazing, isn't it? Only by the power of the wind. This is the power of amplification, the resonance. It's like many a little makes a mickle. So people think the high ISQ values mean good stability of implant, but is it really? Probably not. High ISQ value just means the object or the implant, or implant in this case, is vulnerable to high resonance frequency, which is low amplitude. So it does not necessarily mean it moves little. So they don't have much to do with each other. Okay, we've discussed the problems of RFA so far. So the question is, do we have alternative? Neobiotech came up with this new implant stability meter about 3 or 4 years ago. It's called AnyCheck. So let me briefly introduce this instrument to you today. It shares the same principle with period test. The AnyCheck, since it shares the same principle with period test, it basically evaluates the dampening capacity of implant by measuring the contact time. So the longer the contact time, the mobile the implant is. So let me explain how AnyCheck is different from perio test. When you use perio test, you have to keep certain distance from the object that you're measuring. When you don't have proper distance, like in this case, you hear high-pitched sound. But when you do have proper distance, you hear low-pitched sound. So this measurement is correct. But for AnyCheck, you can literally contact the object directly. You don't need any space between the instrument and the object, the implant. So this is much easier to use in clinic. And also, when the object is highly mobile or soft, like this rubber cup, the perio test cannot measure the contact time, whereas AnyCheck can. Let's see. See, you hear high-pitched sound because it's not really measuring it. The object is too soft or too mobile. But for AnyCheck, for the same object, it measures. Although it's a very low number, which means it moves a lot. The mobility is great. So this is another difference between perio test and AnyCheck. Another difference between perio test and AnyCheck, the tapping force and the number of tapping for measurement is reduced greatly. So this is much more comfortable for patients. With AnyCheck, it hits the implant only 6 times compared to the perio test. It's like 70% less tapping, or less tapping force than perio test. So this is why it's more comfortable to be used on patients. Lastly, when the mobility of implant is above certain level, let's say the fixation is not good. So for example, below 60, the AnyCheck automatically tap only 2 times and then give you the measurement, the reading. Let's see what happened with perio test when the implant stability is low. Plus 3.9 of perio test value is quite high, which means the implant is mobile, quite mobile. But for the same mobile implant, let's see what you get. It hit only 2 times, not 6 times, 2 times. And it gives you AnyCheck value of 59. How about with ISQ? What's the difference between ISQ and AnyCheck? With AnyCheck, you can tap on pretty much anything, any surface. So you do not need any other component like magnetic pad or magnetic transducer you need for Ostel. So this is quite handy to be used on patients. And when the initial fixation of implant is not good enough, if it's too mobile or the mobility is too high, as in this case, the insertion torque was 15 Newton centimeters for number 12 and 20 Newton centimeters for number 22, which was the immediate implant placement after extraction, but the patient still needed provisional restoration. But since the initial fixation was not great, so you probably want to monitor the implant stability for a certain period of time. For me, it's usually 4 weeks. I monitor the implant for at least 4 weeks and then evaluate whether it can be loaded with final restoration or not. So what's nice about AnyCheck is that you don't need to remove the provisional restoration and connect, magnetic transducer that you have to do with Ostel. So you can just simply tap on the provisional restoration directly to assess the mobility change or to evaluate the mobility. See, it hit only 2 times, which means that the implant mobility is not great. It's extremely convenient when we're dealing with multiple implants. Like you can see in this video clip, we're trying to measure 3 or 4 implants at the same time. With our ISQ, you have to connect magnetic transducer on one implant and measure it, and then move it to another, and then try to measure again. This is quite a work. But with AnyCheck, you can just simply tap on each healing abutments and then get some idea about the implant stability, whether it's strong enough, or we should wait more, or we can go ahead and start loading. So to make that decision, this is much easier. And also, like perio test, AnyCheck can measure the stability of the mobility of natural teeth, whereas ISQ cannot. So this is another pros of AnyCheck compared to ISQ, I think. Here's the most critical difference, though, between Ostel and AnyCheck, based on Professor Park's study. I personally like this result a lot. I think this is a great finding between about the difference between ISQ and AnyCheck. Based on his study with AnyCheck first, there was a correlation between insertion torque and AnyCheck value above, when the insertion torque value was above 15 Newton centimeters, right here. It was almost linearly correlated between these 2 parameters. But with Ostel, pretty much the same correlation was found. So above 15 Newton centimeters, there was a linear correlation between the insertion torque and Ostel value. But what's the difference then? Here's the difference. Let's take a look at these 2 circled areas. This is AnyCheck, this is Ostel. There's no dots with AnyCheck, but there are a lot of dots with Ostel. What does that mean? On the right side with Ostel, when the insertion torque is below 15, some Ostel measurements is higher than 60, whereas you do not find any AnyCheck measurement above 60 for the same insertion torque zone below 15, which means what? So you do find the readings with above 60 with Ostel, but no AnyCheck reading above 60 for the same insertion torque, which means there's no false positive reading with AnyCheck. It does not give you false measurements, whereas Ostel can. Okay, this is what I prepared for today. I hope everyone enjoy or share the same idea with me today. And this is the topic for next presentation, and which will be about implant impression. Neobiotech came up with this great instruments for implant impression, and I'd like to share my experience with those instruments with you next time. Thanks for joining me today, and hope to see everyone again next time. Thank you.